We acknowledge the traditional owners of the land on which this podcast was recorded, the Wurundjeri Woiwurrung and Boonwurrung peoples of the Kulin Nation, and pay our respects to their elders, past, present, and future. Welcome to the podcast series of Raising the Bar Melbourne, curated by the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. This special health edition of Raising the Bar, held in May of 2026, featured 20 talks by some of Melbourne's leading healthcare experts and was held across 10 pubs and bars, all in one night. The speakers presented topics ranging from AI and cancer research to understanding ADHD and neurodiversity, helping kids sleep, healthy social media habits, the future of robotic surgery, and much more. In this episode, you'll hear Dr. Jonathan Pham talk about how Melbourne's weather worsens asthma and allergies, and how ethnicity can help predict risk and improve care.
Thanks very much. I'm currently a medical doctor and an early career researcher, having just completed my PhD last year. I work at the Alfred Hospital. I'm a pulmonologist and allergist, which basically means I look after airways disease. So asthma, bronchiectasis, and I also look after people with allergies. So that might be food allergy, drug allergies, hives, anaphylaxis, etc. And so for this first part of the session, I'd like to share with you I guess what you could call my origin story, how I started out in medicine, and later how I kind of integrated medical research into my career. So very early on, when I was a teenager, I watched shows like Scrubs. I think there's a revamp of that now. But I love watching all the doctors, kind of saving lives, solving interesting problems, and being a real help to the community. And so that kind of led me to try to do my best in terms of kind of helping people one-on-one. But then later on in my career, I wanted to kind of expand that and see how I could help people on a larger scale through medical research. And so early in my medical career, I did some humanitarian aid work in Bangladesh and Uganda. And for example, when I worked in Bangladesh, I worked in a charity hospital. It serviced a very, very poor area. Some of these people just making $1 a day. And we also serviced the Rohingya migrants who came across the border from Myanmar. And it was a really, really eye-opening experience. I came into that environment thinking that, I'm going to make a huge change and help people. And I guess what I realized is that so many things happen before they reach the hospital door that, as a doctor, you just can't change. And I guess that started getting the thought process going to, well, maybe there's something more than medicine that I need to be involved in. So, for example, in Bangladesh, so many things are against these people. So health literacy and education is very low, and so therefore they don't have a simple awareness about hand hygiene. They don't have the kind of financial income to spend on a lot of things, so they kind of focus on food and shelter, and kind of it's really problematic, and there's multiple kids and people in one house. It's poorly ventilated, and often they're using wood fire stoves, which is obviously very bad for the lungs, with very poor ventilation in these houses. So that kind of sets up this scenario where, you've got people who already have high risk factors for getting sick. Then once they get sick, it's really tough. They don't go to a doctor because they can't afford to go to the doctor. They go to the pharmacy. And if you want to get the Western medications, you've got to pay extra costs for them. So they've already spent all their money at the pharmacy, and then by the time they reach the hospital, they're nearly at death's door. And so this is very sad, particularly for kids who really are dying over there for very preventable diseases like pneumonia, diarrhea. Okay, so I kind of came out of that experience kind of with my eyes wide open into the fact that there is probably systemic and multi-level disparity in certain areas of our world. That kind of led me to thinking more about research, and I then took a break from medicine for a couple of years, and I worked in respiratory research in London, which is kind of the complete opposite of the kind of scenario that I was working in Bangladesh. And I was a research fellow at the Imperial College London at St Mary's Hospital. So if any of you have been to London, it's in Paddington, so it's kind of in the central area. And while I was there, I did kind of research in air pollution and how that air pollution affects breast milk. So I don't know if any of you have been to London, but it's a massive city. It's 10 million people. That's a third of the population of Australia in a tiny space. So there's lots of people living in very close quarters. And so because of that, it generates a lot of rubbish. Now, their rubbish, often it's incinerated, which is kind of crazy to think. They take all this rubbish from 10 million people and they burn it. And so one of the nearest incinerators is in Southampton, which is only about 100 k's from the city. So you can imagine that there's already a lot of air pollution from diesel and other car exhaust. And on top of that, you've got this kind of pollution coming from from rubbish being burnt, which is crazy. And so what we did was we sampled breast milk of volunteers who lived in the area. Now, at the time, I didn't know what dioxin was, but dioxin is a chemical. It's often found in clothing. It's kind of like a dye. You could call it like a forever chemical. So the fact that we found it in breast milk was concerning. But of course, this is a proof of concept study. We didn't even know what that meant. We didn't even know what that concentration meant. And so just because you find in breast milk, is it harmful? Well, we don't know. But that was the preliminary research I was involved in. And I think now they're starting to try to follow up these kids who were fed that breast milk to see if there are any kind of health defects that they're experiencing. So these studies take many years to complete, but that kind of got me interested more in the epidemiology, big populations, and environmental health. And so since that time, I have kind of come back to Australia. I've finished my my specialist training in respiratory medicine, and then added a couple more years to specialise in allergy. And then, during that kind of latter part of my training, I then kind of started my PhD as well, which I'll talk about in the next session. But basically, my experiences really kind of shaped the kind of career that I want to have. And that is, number one, I want to work as a doctor, and I want to be able to take that experience of looking after individual patients and informing my research, which basically means, when we design research, it's really designed in order to have the outcomes that are going to improve patients' lives. So, maybe improving their quality of life, or their breathing, their fatigue, or some tangible outcomes. And I want to use my medical career to try to influence, clinical guidelines so that lots of people can benefit from the research. And that's a lofty goal, but I always have that in mind when I do the research. How is this going to improve patients' lives? Is this going to be what we call translatable? And then vice versa, it is true as well. If I do research and I'm really passionate about certain areas, then I want to make sure that research is I'm providing the patients that I see in front of me with the kind of most up-to-date kind of research, so they can benefit from the best care possible. So I guess that's the kind of first part of my talk, and I'll kind of invite some questions from the audience.
I'd just like to ask, on behalf of all the people who suffer hay fever, who thought it was going to be once a year, why is it happening multiple times a year these days? Yeah,
that's a really great question, and I guess there's a bit of segue into the third part of my talk. But look, I guess in essence, there's climate change, and that's changing the allergenicity of a lot of pollen. And so we're getting, our group, our research group, have just published a paper showing that the duration of the pollen season is getting longer in Melbourne, which is one, a concern. Number two, it's still very much a huge issue. We have these massive thunderstorms, and they can cause terrible effects. And in fact, myself and one of my collaborators on our team, Nick Osborne, we wrote a paper in the Age newspaper last year. I don't know if some of you saw it, but it is still a huge issue for the public. People are suffering from hay fever, but not just hay fever, also asthma as well. People need to take time off work. People spend lots of money on inhalers, antihistamines, nasal sprays, eye drops, the whole lot. It's a huge problem. And often people call Melbourne the allergy capital of the world. That name doesn't come without some sort of kind of record and these type of things. So yeah, absolutely, it's a huge problem, and we're trying our best to try to figure out exactly what's happening. But yes, thank you very much.
I was wondering how you balance seeing one patient at a time and maybe being frustrated by only seeing one person at a time, and then going to like these population level studies and thinking about heaps of people at a time, but maybe it will affect them in like a decade. Like that must be really challenging to switch between the two. I was wondering how you go about that.
Yeah, look, it is hard. I guess when I'm with patients, I really want to spend a lot of time with them. I might spend like half an hour, 40 minutes with them, and I want to go through everything, their hay fever, their sinuses, their asthma, food allergies, eczema, everything. And I really want to try to make a comprehensive package for them and think about, diet and other things. When you see a patient, you get this, and even when you do kind of studies in clinical cohorts, you get this amazing depth, which means that you can collect or you can kind of analyze all this really rich data. But of course, you don't have the power to kind of generalize it to a big population. And in fact, when you do research on ethnicity, you need a lot of people. So some of those population studies become more important to try to address underprivileged populations. So of course, when they do research studies, often it's kind of very wealthy or healthy volunteer effect, Caucasian people, good socioeconomic status. And so we're not kind of reaching those more hard to reach people. And so when you have a big population, so for example, I did some research in the UK Biobank, that's 100,000 people. Now, of course, 95,000 of them are Caucasian, but that's still a good, 5,000 which are Asian or, black British, and so that's still a big number, 5,000 people, and so you can still do really good analyses on those things. So you do have the breadth when you look at the bigger side of things, and you can adjust for all these sort of things to try to best understand what the problems are. So for the next part of my talk, I wanted to explore a topic that's more dear to my heart. This schematic is made on ChatGPT. Basically, I just uploaded my thesis and got it to make that. So you can it's a bit of an abstract thing, but basically, in this part of my talk, I'll be talking about health inequality in ethnic minority populations, and in particular how that's important in asthma. And so it's a really important area that I'm very passionate about. So much so that I dedicated 5 years of my life to do a PhD in it. And when I first started my PhD, I had just Ollie there, so just one. And in fact, we had him in London, where I said, did the research work. And then by the end of my PhD, I've grown another two people in the family. So that's how long the PhD took. And so I wanted to kind of talk to you about today. One key element of my PhD is kind of ethnicity and how it relates to asthma and what the potential drivers are of that relationship, and importantly, how we can address the inequality to try to improve the lives of ethnic minority populations. And so it's I guess first it's worthwhile acknowledging that there is huge disparity between ethnic populations and asthma prevalence and also asthma severity. So we know that First Nations Australians are more likely to develop asthma and have more severe complications. Likewise in America, Black American children double the risk of asthma compared to white American children, and the list goes on around the world. So, the questions are, often people say, oh, well, maybe it's just the socioeconomics, because there is a socioeconomic difference. But actually, I think that's probably a bit too simplistic, and we should really try to drill down to what is probably something that's very multifactorial. And so when I first started kind of looking into this area, my PhD supervisor said to me, why do you want to look at ethnicity? It's something that often a lot of researchers don't think too much about. And the second thing is that you can't change it. So we can't just tell you, oh, well, be another ethnicity. And so, but what you can do is you can maybe identify what the kind of types of asthma or what kind of presentation or clinical manifestations of asthma there are in different ethnic populations, and are there any specific treatments that we can offer to certain people of certain ethnicities that will be better for them. So giving people more kind of, I guess, bespoke or personalised treatment. And I guess that's the kind of very contemporary and way of trying to practice medicine these days. And so I guess the first issue is that ethnicity is often overlooked in research. Like I said before, a lot of research is conducted in European descent individuals, and this creates major evidence gaps. And so because of that, clinical guidelines are really based on a very biased kind of perspective of ethnicity. And so the guidelines at the moment, especially in asthma, it's trying to apply like a one-size-fits-all, but actually that's not the case, and that's definitely not what we see in clinical practice. The big organisations like NIH in America, which is a large funding organisation that gives a lot of money to researchers in America, for a couple of decades they have mandated in law that there needs to be more research in ethnic minority populations. But even since they have put those laws in place, there's still a massive disparity, and that inequality persists. I guess there might be a few reasons for that, but it may be a bit hard to target, or maybe the will is not there to do it. But whatever the case is, there's still that disparity, which is one of the reasons I want to kind of do my PhD in that area. And so I guess the representation of ethnic populations in studies is an issue. The second issue is that how we kind of consider it. And in a lot of research, what we do is we look at relationships. All right, so let's say an exposure or something that happens to you, and then the risk of developing an illness. So an exposure and an outcome, we call it. And so, for example, let's say we want to look at lung cancer, and we want to say, does smoking increase your risk of lung cancer? Of course, most of us know it does. But for example, in research, we might say, well, we just want to make sure that it's not because of being poor or where you live or air pollution and other things. So what we do is we're going to adjust for it. We use statistics to adjust for it. So we're going to take that out of the equation so we can have a clean signal. And so that's what we try to do. And it's a statistical adjustment. And often in research, we adjust for ethnicity as well, because we think we want to get rid of that. But actually, when we do that, we're kind of ignoring that there could be some differences in ethnic populations. And maybe what we need to start doing is to start looking at what illness looks like between different ethnicities to see if there is a disparity and how we can fix it. And so that's one of the kind of issues about how we conduct the research. The second thing is we should think about, well, what is ethnicity? What are we measuring? What do we want to measure? I guess ethnicity is a very loose term. It's a combination of different things. It's a combination of race, which is, I guess that's a bit of a loaded term, but your genetic predisposition to illness, and then where you live, so environmental things, and then also your culture, which is your behaviour and what you eat, what you do, and so all those things make up ethnicity. So even when we want to research ethnicity, we have to be very clear about what we're trying to research, because then we know how to deliver the treatments for those things. And so I guess we'll start with genetics. Genetics is really important for us to understand. A lot of respiratory disorders now have genetic targets for treatment, and that has revolutionized illnesses. So for example, cystic fibrosis, there's now gene modulation therapy, huge game changer. Now people who used to have a life sentence and progressively falling lung function and ending up having lung transplants, that's not happening anymore because we're targeting those genes. So genetics is really important. And so understanding ethnicity in terms of genetics is important. And we want to look at race when we do that. Now, it is difficult because, like I said, that's a very loaded term. So I guess early anthropologists had this fairly simplistic and reductive classification of race. Basically they said, it's how somebody looks, and it said that you're fixed. So how you look is your race, and that's fixed. That's not changeable. But of course, we know that that's not the case. So genetics is actually, when we think about ethnicity, we actually should, or my argument is we should look at what we call genetic ancestry. So we can look at a percentage of where your genetics hails from. So for example, you might say, well, 80% of my genetics comes from East Africa, or 80% of my genetics comes from a certain place in China. And so that really helps to kind of understand that, it's not a binary phenomenon. You're not African or not African, you're not Asian or not Asian. You're probably a combination of things. And to try to drill down deeper, I think is really important. Then we can also think about ethnicity by nationality. For example, I'm Australian, okay, so I have an Australian passport. When I go overseas, I say people I'm Australian. But of course, where I live doesn't necessarily reflect, my genetics either. So nationality is only one component of it. And then you might say, well, what's my cultural affiliation? So what do I affiliate? How do I kind of represent myself? Okay, I'm Chinese, Vietnamese. So that means that, I eat a lot of banh mi, okay? So, and maybe banh mi is a risk factor for disease. I don't know. So, but those exposures are really important. So how we identify is really important as well. But of course, everyone has a different understanding of how we identify. So that's kind of interesting. And I guess there's also social constructs behind these terms. And I didn't know this, but in Australia and America, if you're from Southeast Asian descent, then we call ourselves Asians, but when you go to UK, Asians is actually another term that's reserved for South Asians, so Indians, Sri Lankans, Pakistanis, etc. So the terms are different depending where you go, but obviously those groups of people are very different. And then likewise, when you look at literature to try to understand it, to read it, now people are using different terms. So, some people use the term African Americans in research because when they compare different ethnicities, they use the term African American. But there are some people who don't like that term because their heritage is so distant from Africa, they don't identify as African, which is fair enough. But, we just have to be careful about what we're reading and how we define people. And so it's a little bit more grey. In the UK, one of the official definitions is Black British. That's what we call it. I mean, we probably, some people would find that term a bit hard to use, but Black British essentially represents Afro-Caribbean individuals who have migrated or been taken across to the UK because of the transatlantic slave trade. So all these terms are difficult. We have to understand the sensitivities and the historical implications, and before we do any type of research. So I think that those things I found challenging, but I think the good thing is that we're very clear about what we're measuring. And I guess I wanted to share with you a couple of things that I've learned through my research in ethnicity. So first is that diet is a huge part of ethnicity, okay? And so what we found is that vegetarian diet seems to be protective of asthma in South Asian populations. Now, if you think of South Asian individuals, I've got a lot of friends who are from India and Sri Lanka, vegetarian diet is massive. And so the fact that it's protective maybe makes sense. But what we saw in the UK biobank population, again, around 5,000 Asian individuals, is that with the compared to people born in the UK and people not born in the UK, the newer generation actually ate less vegetarian food, which maybe is placing them at a higher risk of asthma. So that's really interesting that there's that kind of interplay between kind of culture, migration, and disease. So that's what I found really interesting. The other thing we found is that ultra-processed food, it was a risk factor for asthma across all the ethnicities, but it seemed to be more pronounced in Black British individuals. So maybe because of their genetics, they can't process it as well as others. So if we were to do more research in it and eventually try to make that a kind of dietary recommendation for health, we might say, well, in this ethnicity, we're going to target this diet, and this ethnicity, we're going to target a different diet. And that's really important because we're delivering personalised care for individuals. The second thing that I've identified is that people of East Asian heritage, so in the UK biobank population, this is predominantly Chinese, they were more likely to have asthma at a certain level of BMI. So, for example, you had to be quite obese to develop asthma in other populations, and you didn't need to be that obese in the East Asian populations. So that means that maybe what we need to do is be more careful of the East Asian person who's got a little bit of weight on them compared to other ethnicities. And what we found was that mechanism really drove non-allergic mechanisms, which basically means that the thing that drives that is not necessarily allergy, and therefore there are other processes that we need to focus on, other treatments. And so when we look at BMI across the board, similar with other conditions like heart disease and diabetes, we really need to have that kind of ethnicity lens when we look at BMI in Asian populations. So that's, I guess, a brief overview of what my research in ethnicity looks like, and I'm very happy to take questions.
Hi, I'm wondering if your research looked at immigration and how that affects allergy development in individuals who, let's say, have lived in a certain place of the world for many, many years growing up and then immigrated to Australia or North America, and how that affects asthma or their allergy development?
That's a really great question. And certainly we did see that there's a small difference between first and second generation individuals and asthma in the UK population. It's not massive, but it's small. But when you add it onto your gender, which we won't talk about today, but when you add on migration, gender, obesity, ethnicity, when you add them all together, I've developed a kind of risk tool, which hopefully we're hoping to kind of publish and incorporate into guidelines. But all those things together kind of have almost a synergistic effect, or at least an additive effect. So yes, absolutely, migration is important. There's been lots of studies showing that first compared to second generation Chinese Australians, second compared to first generation Chinese Australians, are more likely to have worse hay fever and worse asthma. So that's been kind of established before in the research. And in fact, that's from my colleague Roland Leong, who did his PhD at the Alfred, is one of my predecessors. And what he literally did was he looked up all the Asian surnames in the Alfred database and he called them up and he asked them a questionnaire. That's how he did his PhD, which is incredible. So it's definitely it's a recognized phenomenon. But yes, it's not just about migration. There's probably other complex things as well. So
this is a little bit about the first point you made as well. But something you mentioned was subpar medicine. That's what's only available to like the lower income people. But like a trend with a lot of medicine is that like when it's first made, it's expensive, and then like usually the patent expires or something, and then people like make the cheaper versions of it. So considering that, is there like having access to this subpar medicine, is there any harm in it, like because it's subpar, or like would you rather take the subpar medicine or not at all? Like how bad is it?
Yeah, that's a really great question and very important for developing countries. I guess, in medicine we have a phrase, first do no harm. And so what we don't want is people to have contaminants in the medication or to have, not enough active ingredient there. So that's important. I'm all for, things coming off patent and having generic. I'm all for that. But I guess, it's really important that, the government has ways to regulate these things to make sure there's a minimum standard, okay? Because in some countries that's just not available. And if you don't know what you're putting in your child's mouth, would you do it? I've got 3 small kids, and if I don't know what's in a certain medicine, I can't be sure what it is. I probably would be very apprehensive about doing that. Now, of course, if I'm in a situation, it's do or die, and I have no choice, of course, then I might make that call. But it's really up to medical institutions, research institutions, and governments to make sure that we're providing safe care for the community. So for the final part of tonight's session, I'd really like to talk about my current research interests. And that's in pollen allergy. And at the moment, I lead a team called the Prepare team. And our aim is to improve asthma and pollen allergy through an integrated method. So we want to try to pool across different specialties, including clinical medicine, immunology, botany, and epidemiology, to try to develop an integrated e-health tool to help people, and hopefully this will help to improve health inequality, because everyone's got a mobile phone, and hopefully you can just use it to help with your asthma and allergy. That would be good. And I kind of have leveraged my experiences working as a specialist, having collaborations with different laboratories to kind of lead this group as an early career researcher. Of course, supported by a very senior team with a good track record. And so I wanted to kind of maybe start with a little kind of vignette, I guess you could call it. The 2016 Melbourne thunderstorm epidemic. Now, the word epidemic, I guess, has a very different meaning these days. But back then, we kind of used it for this kind of very local event in Melbourne. Does anyone remember that event? Were people there? Yeah. So it's still fresh in people's minds. It's 10 years ago, right? So it's still there, right at the forefront of people's mind. As we said here, like people are still suffering from allergies, and people who had allergies who were affected in the 2016 thunderstorm. It's still a very, very kind of key issue for them, and something that people think about. Now, I guess I wanted to just paint a picture of what happened on that day. So, if you imagine, in 2016, we're at the height of springtime. And Melbourne has just come out of a very, very kind of rainy, cold winter. And because of that rain, there's a lot of grass has grown. So there's heaps of grass around, particularly in the west of Victoria, where there's a lot of farms, with a lot of what we call ryegrass. And so because of this large volume of grass, then of course there's going to be a lot of flowers, right? In springtime, that's when the grasses grow. There's flowers, and when the grasses flower, they release an invisible kind of thing called pollen, and pollen's kind of like the sperm of the plant world. It's there to reproduce, right? So, and I guess it's something that the plants need. But for humans, if we breathe that in, we're going to get airway inflammation, which manifests itself as kind of sneezing or hay fever, and asthma, so the wheeze and shortness of breath. So. There's lots of pollen in there already. And then in 2016, in November, there is a massive thunderstorm. So it's kind of like the perfect storm, we could say, like all these things kind of aligning in one to create this very devastating environmental catastrophe. And so what had happened was there's a huge thunderstorm, particularly in the west of Victoria, and that thunderstorm has caused the pollen grains to rupture. Okay, so now there's all this pollen in the air around the grass. Now, it's in the west of Victoria, and then what happens is there's a wind. Okay, it's a big storm, a big wind that blows that pollen from the west Victoria all across Melbourne. It basically blankets Melbourne with all this pollen. And so the pollen level that's measured in the air, it's unprecedented. We've never had that high level of pollen ever. It's a crazy amount of pollen. The air is essentially toxic. And so within the space of a few hours during this thunderstorm, there are 3,000 ambulances called. That's amazing. There's just no space in the emergency departments. There's just ambulances everywhere. There's people ramped out in front of the emergency department. Some health services even run out of Ventolin, which is crazy. Ventolin, you can get that from any pharmacy. It's $10. It's not expensive. They've run out of Ventolin completely. People are having asthma attacks in ambulances, in emergencies, and we've got to use adrenaline. We've got to use EpiPens to revive these people. It's crazy. And so, unfortunately, tragically, 10 people have died that day. So it's something that has been published by our team at the Alfred in international journals. It's a freak event, but it's definitely something that's happened once. It can happen again. So we as Melburnians, we've got to take that really seriously. Now, I guess tying in with the previous section that we spoke about ethnicity, Asians are 2 times more higher than general population of ending up in emergency, and they're 5 times more likely to die. So there's definitely something in that Asian populations which makes them more vulnerable. Is it genetics? Is it poorer access to healthcare? We don't know, but it's definitely an issue. I guess the second thing is climate change. We kind of touched upon that before. So climate change, it's making kind of allergens and different plant species grow that they previously didn't have. And so things like ryegrass are now spreading up the east coast into places that didn't have it before. And likewise, in Melbourne, we have a lot of subtropical grass. This is grasses from Queensland that have come down. So there's a lot of exchange of different type of allergens. And so what we really need is a system that can adapt to all these things. We need to be able to diagnose these things. We need to make sure that people know exactly what their risk is. And we need to develop treatments to try to protect us all. And so within this, within that context, we have developed a kind of research program that really looks at 4 different processes. So we're trying to best describe to you as the individual patient what you're actually allergic to. Okay, we're going to try to figure out where the hotspots are for you. So let's say you're allergic to a particular grass, and we know that that part of Victoria has a lot of that grass. We can tell you, don't go in that area or get out of that area now. Then we can tell you, okay, we want to try to ascertain, when is this likely to happen for you? And then the how is to bring all these things together to really give you up-to-date medical treatment on your phone, okay? To tell you, okay, you're at risk, go inside now, or you're at risk, your asthma is getting worse, increase your Ventolin or increase your inhaled steroid, etc. And then ultimately what we want to try to do is formulate to understand what your particular individual mix of allergies are, to develop a kind of cocktail medication called immunotherapy to give to you to basically cure you of that allergy. So that's called desensitization is a common word for it. So that's the kind of process to this. And I'll kind of discuss that in detail about how we do that. So the first issue is, what you're allergic to. So has anyone seen an allergist here for their allergies? Okay, got a few people, yes. I think, did you see me at the hospital? Yeah, okay. Yeah, so my patients, I haven't paid them to be here, but all right. And so, do you remember how they diagnosed your allergies? What test they had?
Blood test and a skin prick.
Skin prick test, yeah. You have a diagnostic test, a skin prick test. Then you'd go on immunotherapy, like desensitization, and then hopefully 15 years later, you're still cured. So that's the gold standard. But what I want to bring your attention to is, what was your name, sorry? Anne. So what Anne is very perfectly demonstrated is that 14 of those tests are positive. So how do we know which one is the problem? And that's very common for the other people who've had allergy tests. That's super common. So many different allergens on there. And of course, every time you do immunotherapy, that's 3 years of a particular treatment with a particular allergen. We couldn't possibly do that 14 times. So we need to have a better tool to understand what your allergies are. And so what our team has developed is something called Cytobas, which is a type of component-resolved diagnostics. So what component-resolved diagnostics means that when we do a skin prick test, we basically just take the grass, grind it up, and then put it on your skin and scratch your skin. Right? It's very, very crude. But what we want to do is we want to look inside that grass and what is the particular molecular level protein that is driving your allergies. So when we do that, we can say with more certainty that, this one is the one that's your real problem. And the other thing we want to do is have a functional test because, like you said, there's 14 different allergens there, but which one is the most significant? Now, you can measure them and see which one is the biggest, but of course, they're all big. And so we've got a test called basophil activation, and what that does is that kind of tells us what the strength of that allergy is. So that's what we're trying to develop. But what we need to know is that to do that, we need to know, okay, well, what, if we have all these positive tests, what do they actually mean? So we want to surveil people at the Alfred Hospital, and we want to try to understand when their symptoms are across the hay fever season. Is it early? Is it middle? Is it late? Is it across the whole season? And then we want to try to compare that with the blood test results to try to figure out what the patterns are. And essentially what we want to do is we want to have a single test, a single tube. You give it to people, and then it can tell you, okay, these are the allergens. These are the allergens that are most relevant for you. So at the moment, the government allows you to do 4 RAS tests. Okay, so that's not really enough. What we want is to develop one single tube. You come in once, we figure it out, and then we tell you exactly what you're allergic to. So that's the what. We will try to identify what you're allergic to. Then the second question is, where can you go? So where you can go is really dependent on the certain type of plants or pollen that you're allergic to. So for example, ryegrass we talked about before, that really peaks in kind of October, November. But we need to know where you are. So if you're inside your house and not going anywhere, you're not exposed to ryegrass. However, if you're out and about, particularly in Western Victoria, maybe you're going to be more exposed to it. So we need to know where you are, okay, to determine your allergies. To determine your exposure. And we also want to know what your symptoms are. And when I see people in the clinic, I say, okay, what months of the week did you have the worst hay fever? People can't often remember. But if we have an app to do that, You put in the symptoms every day. Geolocation, we collect your geolocation data on your phone to say, oh, okay, that's the allergen you're exposed, and we can tell you, hey, you're exposed to that, and more particularly, don't go in that area or whatnot. And then the when is really about, okay, so what are the actual grasses that are causing a problem, and what time of the year does it do that? At the moment, the government has what we call general pollen counters. So it just measures all the grass pollen in the air. We don't know what species they are. And our team has recently published a paper showing that other than ryegrass, which is very important, especially for thunderstorm asthma, we have now identified something called bent grass. They're both temperate grass, both springtime grasses, but that bent grass has a unique signal, which is later in the season, so maybe early December. We didn't recognize that before. Now, we talked about before about climate change causing new species that we didn't recognize, but we need to have these mechanisms. We need to have these tools to constantly sample the air using, which we use kind of DNA methods and also proteomics to try to constantly analyze, constantly find new allergens so we can be prepared for climate change if there's any changes in the environment. And then the last part is about how. So how do we... So we've done all these three different areas. We've got better laboratory testing, we've got geospatial information, and then we've got really kind of precise botany kind of tools. But how do we put them all together? Well, what we want to try to do is combine them all together on an app. And that's essentially what we're trying to do with this project. And apps, we can make it free. We can generate the intellectual property for it. We can have it university-based, and we can make it free for people, so that we don't have to have this disparity. Maybe we can enter, the ethnicity data in there. Maybe that's important for certain things like thunderstorms. So I guess that's just a brief overview of what I'm doing now, and I'm kind of very happy to have questions.
My question for you is how much do you think it is a question with allergen immunotherapy of the what? Or is it also the who? That is, who pays? So we have a market failure in Australia where the PBS system doesn't fund allergen immunotherapy, and nor do many health cover funds. So is it enough to answer the what question if we don't also answer the who pays question?
Yeah, that's a really important question. I guess all researchers here would have a similar issues. I mean, who's going to pay for your research, let alone what we do with it? I mean, and we're all kind of applying for grants and trying to get money from that. But that's a really, really good question, Adrian. And I think it's really tough because, the issue is that we don't know how much. So in terms of kind of health economics, I guess we really need to know how much allergy is driving asthma presentations to hospital, because funders want to know that if we're going to fund medication, we want to save money in public hospitals. Public hospitals are already so full, etc., and it's really hard to do that. And I think that we talked before about what's the value of big data, and maybe if we look at statewide data, or national data, we can generate some of these understandings to be able to tell the government actually, allergy is responsible for X amount of hospital presentations for asthma within this time frame. And I think that's really important. And I guess that's the only way to try to get the money is to try to show the government that you're saving money. Everything's about money, right?
2 questions. Firstly, why are food allergies exploding? And secondly, where can I go for a holiday in springtime to get away from the ryegrass that's not too far away?
I'll start with the easier question, which is the second question. Ryegrass is not really around in Queensland. Okay, Queensland's got a lot of subtropical grass, but if you're allergic to ryegrass, then Queensland's the place to go. The reason is because Queensland's too hot to grow the ryegrass there. So, so if you want to go to, Gold Coast, go to Movie World or something like that would be okay. Yep. And the second part of the question is about food allergies. Why are they kind of, well, we don't know. That's not the area of my research, but I guess we definitely know that there's something going on with Australia compared to other countries. So Adrian can probably expand on this further, but when we looked at the health nuts population, so that's a group of children which we follow up over time, what we did was we compared kids from Melbourne who are Asian, Chinese heritage, who grew up here. They have a much higher rate of food allergy than Chinese kids in Singapore. Now, Same genetics, both Chinese, okay, but worse food allergy here. So why is it the case? I don't know. But clearly there's something to do with the environment. So is it because maybe breastfeeding is not so prevalent here? Is it because early introduction of food is different? Or maybe it's ultra-processed food? We talked about that before. These are really, really important questions. Food allergy is a massive cost for the government because kids and even adults with food allergy end up in hospital, yeah? And they take up emergency beds. And also, from a patient point of view, it's life-threatening, if you accidentally eat something. And what we're also discovering now is that there's a massive mental health burden for food allergy. If you're allergic to something, maybe you don't want to go on holidays. Maybe you don't want to go out to have dinner with your friends because of it. So there's a huge cost, not just related to healthcare dollar, but also patients' lives. And it's definitely something we need to look into further. So thanks for your question.
Thank you for listening to the podcast series of Raising the Bar Melbourne, a special health edition. If you want to listen to more Raising the Bar talks, head to rtbevent.com/podcasts.